So we're going to spend 30 minutes on developmental masses of the neck. I think this is a topic that hopefully when you leave here, you'll be a little bit more comfortable the next time you get a neck mass in a kid and you think, oh, I'm going to leave that one for somebody else to read, because it really is pretty basic. We can't always tell 100% what it's going to be, but I think if we use the real estate people, location, location, location means everything. Where are they coming from? What do they look like? We can pretty much narrow our differential diagnosis and frequently tell them exactly what it is. So we'll review some normal embryology, which I think gets everybody's blood pressure up a little bit, and then the imaging characteristics of what these lesions look like. Thyroglossal duct cyst in a kid looks just like it does in the adult. Just remember that that duct starts at foramen cecum, descends, wraps posteriorly around the hyoid, and then inferiorly into the neck. So anywhere along that track, you can have secretory epithelium, you can have a cyst, you can have little deposits of thyroid tissue. What happens to them? They can become infected, they can rupture, they get fistulae. If there are little remnants of thyroid within the cysts, they may ultimately end up with thyroid cancer within them. So we treat them. And how do we treat them? We take out the entire tract. Not we, but the otolaryngologists take out the entire tract from the base of the cecum, or base of the tongue, take out the tract. They also take out a little bit of the midline hyoid. So on a post-op image, you'll be missing that midline hyoid. And that gets recurrence down to less than 3%. Still a risk of recurrence even if you do the cyst-storing procedure. We at our institution do an ultrasound, not to look at the thyroglossal duct cyst necessarily, but to look to make sure that there is a normal appearing thyroid gland in the lower aspect of the neck. We'll also tell them what the thyroglossal duct cyst looks like. Clinically, they can tell it's usually midline. When they swallow, it elevates. If you see internal echoes, don't worry about it. Histologically, internal echoes within a thyroglossal duct cyst do not correlate with prior hemorrhage or infection, so oftentimes they'll just have proteinaceous fluid within them. We describe them, tell them where they are, but don't forget to put in your report there's a normal appearing thyroid at the lower aspect of the neck. Multiple cases, one at the base of the tongue, well-defined, round, usually low attenuation, water attenuation on CT. Not infrequently, we see them incidentally on an MR. If you look at that coronal T2 weighted image of the brain, if you happen to catch the floor of the mouth, the base of the tongue, you'll frequently see incidentalomas. Here's one right at the hyoid. Most of them are at or above hyoid. The ones that are infrahyoid are classically embedded in the strap muscles, so that might be a clue. Well-defined, no enhancement, just a benign thyroglossal duct cyst. Here's one, though, that has a thick rim of enhancement. The fat around it is edematous. This one presents with cellulitis, acts infected, and turns out to be an infected recurrent cyst in a kid who had a previous cyst-storing procedure. As I said, along that tract, you can have cysts from fluid in the remnant, or you can have thyroid tissue actually along the tract. And the most common location for ectopic thyroid is at the base of the tongue. So 80 to 90% of them are going to occur at the base of the tongue. On CT, they look just like they do, like the normal thyroid. They're hyperdense on a non-con study, like this one at the level of the hyoid. If you see one deposit, look for another, as we see in this child who has a little second deposit at the base of the tongue. So this child presents with a submandibular mass, but has a second deposit. Did a technetium scan and proved just 2 foci of uptake, nothing in the lower neck on the tech scan. If you do an MRI, though, you may be a little bit confused because the normal thyroid being bright on T1 and T2 weighted images, ectopic thyroid doesn't always look the same on an MR. Normal thyroid will enhance, ectopic thyroid may not. So you may have heterogeneous enhancement, you may not have a lot of enhancement, and the T1, T2 characteristics may be variable. You guys have heard this a few times. I'll preach one more time. All the way back to 1982, and here we are in 2014, and people still aren't using this classification. You're either a hemangioma or you're a vascular malformation. The hemangiomas proliferate, they involute, they appear right after birth or within a couple of weeks. They're GLUT1 positive. All the other things are vascular malformations, and they're named by what makes up the most prominent endothelial characteristic. And Mulligan and Glowacki looked at these. They looked at the histology and the behavior. The vascular malformations are going to grow with the child. The hemangiomas are going to grow and then involute. This is the International Society for the Study of Vascular Anomalies classification, updated in April 2014, very similar to 1982. You've got vascular tumors, benign and malignant, and then vascular malformations, either simple or combined. So if we look at the lymphatic malformations, what do we want to tell the clinicians? We want to tell them, is it unilocular or multilocular? Is it in one space or more than one space? Microcystic or macrocystic? And a real big hint in the lymphatic malformations is the presence of fluid levels, because this is the most common cystic malformation to undergo intralesional hemorrhage. So you have blood products within the cyst, you have fluid levels within the cysts, and if you see either a unilocular or a multilocular cystic mass with intralesional hemorrhage, it's almost always going to be a lymphatic malformation. The lymphatic portion may have minimal septal enhancement, a little bit of peripheral enhancement, but intrinsically should not enhance. If you have an enhancing component along with what looks like a lymphatic malformation, it's going to be either an associated venous malformation or what some are now saying just dysplastic veins along with your lymphatic malformation. But the lymphatic malformation itself is not going to enhance. Here we have 3 different kids, one with a unilocular macrocystic with a fluid level. This appeared over a period of a day or two. Didn't have it previously. Probably it was underlying present, but not clinically present until he hemorrhaged into it and it got bigger. Another child with a multilocular transspatial lesion, which if you squint, there is a fluid level there. It's in a similar location that we'll see as a second branchial cleft cyst, but it's multilocular. It's going in between internal carotid artery and jugular vein and has a fluid level. So that's going to be a lymphatic. And then another child, which unfortunately this is not an uncommon appearance, where we have the massive anterior neck lesions in a kid, in an infant. Frequently these are diagnosed on prenatal ultrasound with the differential diagnosis of a teratoma or a lymphatic malformation. The presence of blood products and fluid levels pretty much clinches the diagnosis of a lymphatic. Venous malformations used to be called cavernous hemangiomas. Please get that out of your vocabulary. Venous malformations are dilated lakes of veins. They may look cystic on a pre-con study. Their hallmark is the presence of phleboliths. They'll have heterogeneous enhancement on a post-con study, and then you can look for other things in the head and neck. You might have bony hypertrophy of the adjacent mandible. You can have fat hypertrophy with these. The muscles next to them may be actually atrophic. And keep in mind that the classic facial nerve geniculate ganglion hemangioma, quote unquote, is not a hemangioma. It's a venous malformation. We now have histologic proof that these are GLUT1 negative lesions, so the geniculate ganglion lesions should no longer be termed hemangiomas, just like the vertebral body lesions should not be called vertebral body hemangiomas anymore because they're venous malformations. So what do you tell the clinicians? I usually put in my report, consistent with a vertebral body venous malformation, parentheses, formerly known as hemangioma, and I put it in quotes so that we're kind of all trying to speak the same language if the clinicians aren't used to seeing venous malformation in the vertebral body. Sometimes you can have lesions that appear to be mixed. So we have a child with a very large submandibular fluid level and a macrocystic, fairly unilocular lymphatic malformation. Not much enhancement along the front wall, a little bit of enhancement along the back wall. And if we go north, he has a very large tongue. Heterogeneously enhancing venous malformations in the tongue are not uncommon. He has a few little areas of non-enhancement in the anterior tongue, and then look in both parotid spaces, non-enhancing cystic malformations in lymphatic component in a multi-level transspatial lymphatic malformation with a venous component involving the tongue. Okay, so this one sort of gets everybody's heart rate up, gets a little hypertensive, but I think in general, just a reminder that we all start out the same. We've got 6 mesodermal arches, 5 paired internal endodermal pouches, and then 5 paired external ectodermal clefts. So external ectodermal with a C cleft, internal endodermal pouch. As that whole apparatus develops, the second arch overgrows the second, third, and fourth cleft to form what's called the cervical sinus of His. Notice that the third pouch, actually, if it doesn't involute, ultimately is going to end up like a thyroglossal duct, and it's going to form the thymopharyngeal duct, and then we'll talk a little bit later about what happens when that embryology goes awry. Many charts in the literature, what happens to those arches, pouches, and clefts. Each one has structures potentially that form the adult craniofacial structures. You'll notice that second, third, fourth, fifth clefts are rudimentary. Keep in mind that the first cleft is involved in the EAC formation. The third pouch is involved in thymus, and the fourth pouch is partially makes up the piriform sinus. Notice that a portion of piriform sinus also comes from the third pouch, and we'll discuss that a little bit later. The apex of the piriform sinus is supposed to come from the fourth pouch. So if embryogenesis goes awry, you can have all of these craniofacial anomalies, but you can also have a cyst, a sinus tract, or a fistula. A sinus tract, by definition, should have an internal or an external drainage, not both. A fistula has an internal and an external connection. So if you only have an outer or an inner connection or a drainage port, then you're a sinus tract. If you have both, you're a fistula. And then are these branchial cleft cysts, or are they branchial pouch cysts? Some of them come from a cleft, some of them come from a pouch. I don't always remember, so I actually like to call these branchial apparatus cysts or branchial apparatus anomalies, and then I don't have to remember which is a cleft and which is a pouch. Most of the cysts and sinus tracts that we are going to image are going to come from 1 to 4 cleft or pouch. And then remember, you can have the ectopic or aberrant thymus, and then the craniofacial and temporal bone abnormalities if you have embryogenesis that goes awry. So the first branchial cleft, branchial apparatus anomalies are in and around the ear. They're the second most common of all the branchial anomalies, with the second branchial anomalies being the most common. But just keep in mind that if you see something around the external carotid or external auditory canal or the parotid, lots of these are little pits that we don't image. Some of them are skin tags we don't image. But if you see a cyst in or adjacent to the parotid or somewhere along the external auditory canal, keep in mind that that might be a first branchial apparatus cyst. Also, they can extend down to the angle of the mandible. And so if you see something at the angle of the mandible, try really hard to trace it backwards or a craniad to see if there's any connection with the external auditory canal, because the clinician's going to need to know that. The most common classification for the first branchial cleft cysts is the Work classification from the early 70s, and they divide them into type 1 and type 2. Type 1 being up by the EAC, and the type 2s extending more towards the angle of the mandible. And if you look, the type 1s were thought to be ectodermal, which would have been a cleft origin. Type 2s, ectodermal and mesodermal, so they're not always purely cleft. Here we have a kid who has an intraparotid, low attenuation, cystic appearing mass, and on coronals, it has that little beak towards the external auditory canal, and they frequently point right towards the junction of the bony and the cartilaginous external canal. Another child who presented with a mandibular angle of the mandible mass, and on the coronal T2 weighted images we could trace it back to a little cyst right next to the external auditory canal, so giving them an idea that this is a first anomaly more complicated than just a simple cyst at the angle of the mandible. And the really high-res coronal T2s I actually prefer for the first. So if the clinician calls and says, this is what I suspect, how do you want to image, I would go straight to an MR and do the high-res coronal T2s, looking for that little fluid-filled tract that you might actually miss on a CT. Second branchial anomalies are absolutely the most common, and this is the one you guys see most frequently. Keep in mind that at our little children's hospital, where we're only dealing with kids, rarely are we going to see a necrotic node simulating a second branchial apparatus cyst. But if you're doing a lot of adult work and you get something that looks just like what I'm going to show you, if it wasn't there before and it's just now appearing, you certainly have to keep in mind that a metastatic squamous cell or thyroid cancer node could present just like a second branchial apparatus cyst in the same location. They're all anterior to the sternocleidomastoid muscle, most commonly. Here we have one in the classic location. What does it do to its neighbors? It pushes submandibular gland forward, it pushes sternocleidomastoid muscle backwards, and it pushes the carotid sheath vessels medial. So in this case, we have sort of a thick-walled lesion, little bit of strandy fat. This was an infected second branchial apparatus cyst, and it's the most common in the classification of second branchial apparatus cysts. They can be parapharyngeal, or they can be occasionally like this one. So he's sitting in the correct place, doing what it's supposed to do to its neighbors, but look, it beaks in between the internal and the external carotid artery. So don't automatically say that's a lymphatic, because it might be crossing spaces or splaying arteries. This is a rare variant of the second branchial apparatus cyst. Just like hemangiomas and vascular malformations, or anything we image in radiology, if you see one, look for another. If you see one abnormality, look at everything else. So you're going to want to look, is there a branchial apparatus cyst on potentially both sides? Look north, as Dr. Robeson so nicely described. Is that cochlea unwound? Is the base turn of the cochlea further away from the middle apical turn than it should be? Just like if you're grabbing a coil and trying to unwind it. And then, while you're there, look for the eustachian tube, that patulous eustachian tube, and you may be the first one to suggest that this kid has branchio-otorenal syndrome, only based on the corner of the image, the temporal bone structures that are included in your neck CT. True third branchial cleft cysts, I think, are incredibly uncommon. They follow the course inferiorly, similar to a second, but they should be in the posterior triangle in the upper neck. I've had several cystic masses, posterior triangle of the upper neck. I'm all excited. I'd like to call it a third cyst, and most of them in kids turn out to be lymphatic malformations. Put it in the differential. It could be either or if it's in the posterior triangle of the upper neck. The most common third anomaly that we see are remnants of that thymopharyngeal duct. So the thymopharyngeal duct, just like the thyroglossal duct, can have secretory epithelium along its tract, or it can have deposits of thymus. So we can have a thymic cyst, or we can have a barren thymus. These are third pouch remnants. They are closely associated with the carotid sheath. And in the literature, our most common left-sided, we'll see that the next anomaly that we talk about is almost always left-sided. Our review says that most of ours are actually right-sided. So the left-right doesn't quite help you. The intimate association with the carotid sheath, I think, helps a lot. If you have a cystic lesion that's splaying the carotid and the jugular, especially in the suprahyoid neck, that's frequently going to be a thymic cyst. If you get lucky, the cyst is in the neck and it extends all the way down to the anterior mediastinum, and then we can say it's a thymic cyst. If it doesn't extend on imaging all the way to the mediastinum, then you might be left with a differential diagnosis, but that association with the carotid is very helpful. Histologically, there are hostile corpuscles in that wall, and that's how they make the diagnosis after it's resected. So here we have a child who is an easier one because he has a cystic mass splaying carotid and jugular in his upper neck, and if we follow it all the way down, it's in his mediastinum as well. That's what they look like. This one was actually resected from a neck incision with blunt dissection all the way down to the pulmonary artery. And here's another child who presented with sudden onset of a neck mass, nothing that looked like infection, and he had this cystic lesion with some internal echoes that were moving around. Is that protein? Is that blood? We weren't sure what it was, and so he ended up with a CT, and again, that classic splaying of the carotid and jug by the cystic mass deep to the sternocleidomastoid muscle in a kid with a cervical thymic cyst. Occasionally, they'll fool you. This is a multi-septated transspatial lesion. Notice it is also going posterior to that piriform apex. Transspatial, cystic, lymphatic next. I was wrong. It turned out to have Hassel's corpuscles in it. It was a cervical thymic cyst. I got another one of them 6-8 months later, told him the same thing. Transspatial, multiloculated, lymphatic, and it came back to be thymic cyst. So just, we're not always right. And then keep in mind that along that tract, you can have a cyst, you can have solid, or you can have mixed. So here we have a kid with a solid rim lateral to the cystic component. On T2-weighted images, it's sort of intermediately bright along the solid anterior wall, and there's a little bit of rim enhancement at the inferior aspect of the cystic appearing portion. And we've had a couple of kids with synovial sarcoma in the head and neck, which are partially solid and partially cystic. So our concern was, is this a synovial sarcoma? And it turned out just to be a mixed cystic and solid remnant. Another case, similarly, we have an echogenic material within a cystic portion. We have the typical dot dash appearance of what mediastinal thymus looks like on ultrasound. The inferior portion is cystic, the superior portion is solid, and notice that that superior portion on this image is isointense to the normal thymus in the chest. So that's a mixed cystic and solid thymic remnant. Also remember that we have normal variant extension of the mediastinal thymus above the suprasternal notch, which is really common in kids. Over time, the incidence decreases as noted in this article out of Cincinnati a couple of years ago. We had a couple kids referred for a suprasternal mass, and we all thought they were thymus, and so we said, well, maybe we should look and see how many kids really have this, and they looked at chest and airway MRs to get the incidence of up to 66% of kids are going to have that extension of thymus suprasternal with the same signal as the mediastinal thymus, so we're confident that that's not an abnormal mass. The fourth branchial anomalies and more recent literature suggests that this is maybe a third pouch instead of a fourth pouch, but classically are the piriform sinus quote-unquote fistulae, but there's really only one opening, so we're going to call them sinus tracts. And these are the kids who have a sinus tract from the piriform sinus down to the neck, always left-sided, and they present with recurrent thyroiditis or recurrent abscess in the neck. And so you, again, as the radiologist, may be the first one to say, hang on, this isn't just your typical suppurative node gone awry. This is in a location where you really need to go search for a piriform sinus tract as a cause of that abscess. If you do a CT, you've got a phlegmon in the anterior neck. It's right in front of that left thyroid lobe. This should be a key, and you should right away say, by location, we're really concerned that this is a piriform sinus tract. On a barium swallow, the tract comes out anteriorly, and on a post-barium swallow CT, you can see that barium settling in that tract after the patient's been treated with antibiotics. Here's another child. No known history, presents with this abscess that's occupying pretty much the left lobe of the thyroid. They treat him with antibiotics, give him a little swig of barium, put him on the CT table, and define that tract. And lastly, head and neck dermoids, epidermoid cysts. Most of these in the head and neck are in and around the nose or the orbit. Occasionally they occur in the neck, and sometimes they can be a little bit of a diagnostic dilemma if they don't have fat or calcium within them. If they have fat or calcium, it's a whole lot easier, and we can call them dermoids. But the epidermoid, which is only ectoderm and usually fluid-filled with variable signal and intensity and attenuation, or the dermoid without fat and calcium sometimes can look similar. So if you see a midline or paramidline cystic lesion, remember that a dermoid or epidermoid cyst can live in that part of the neck. So here we have a kid with sort of buried in the strap muscles, but it's off midline, it's coming towards the midline. Is that a thyroglossal duct cyst that's off midline or a dermoid cyst? Turns out to be a dermoid cyst. And another one with a hyperintense T2 signal midline mass in a patient with an epidermoid. So what are our take-home points? Most of our developmental masses are actually going to be cysts and not solid. Thyroglossal duct cyst, remember how they remove them, remember where to look anywhere along the tract, and remember that 75% of them are midline, but occasionally they're off midline. Ectopic thyroid, most common location is base of tongue. And if you see it on MR and it doesn't follow what you're used to seeing as thyroid gland, signal-wise, it's okay. It doesn't mean it's not ectopic thyroid, because ectopic thyroid doesn't always appear like normal thyroid on MR. Lymphatic malformations, what do they want to know? How big are the cysts? Where are they? Is it unilocular, multilocular? And if it has a fluid level in it, it's probably going to be a lymphatic malformation. Try to get that hemangioma word out of your vocabulary, except for the infantile hemangiomas who present in the typical fashion, or occasionally the congenital hemangiomas, but we won't go there. Use venous malformation in your reports for the geniculate ganglion and the vertebral body lesions. And then if you're suspecting a branchial apparatus anomaly, where is it? If it's in and around the ear, the EAC, the parotid, the surgeons want to know, is it going towards that external auditory canal? Because it may be an underlying first branchial apparatus anomaly. Might also hang down to the angle of the mandible, so don't forget that. Don't let that dissuade you from thinking that it might be a first. The second branchial apparatus cyst, they love to be anterior to the sternocleidomastoid and do what they're supposed to their neighbors. If you're imaging the adults, don't forget that necrotic node can look just like it. The third pouch gives rise to the thymic cyst or the aberrant thymus or the mixed cystic solid lesion. Carotid sheath right next to it, its intimate association with that is a tip-off to the fact that it might be a thymic cyst. Third or fourth pouch also gives rise to that piriform sinus tract. Those kids present with recurrent thyroiditis or a left lower neck abscess. And then lastly, the dermoid epidermoid, if it's got hair or fat, just like anywhere else in the body, we can raise that